For clinical examination, we can start off with the cold test. The cold test will cause contraction of dentinal tubule fluids, which will stimulate the pain receptors in the patient. It can be repeated 5 minutes later if needed for more accurate results. There are 3 methods. First is the ice method, the refrigerant spray method, and the carbon dioxide snow method. For the ice method, you have to isolate the tooth with a rubber dam to avoid thermal stimulation of multiple teeth. For the refrigerant spray method, you can use ethyl chloride or dichlorofluoromethane. You require a carrier such as a cotton pellet saturated with the substance prior to direct contact with the tooth. For carbon dioxide snow, it is actually a dry ice in pencil stick form which is applied to one tooth at a time with the aid of a supplied plunger. The cold test enables us to differentiate between reversible pulpitis, irreversible pulpitis, and necrotic pulp, which produces no response in the cold test. For pain, if you have a lingering effect, it will be irreversible pulpitis. If the pain subsides immediately upon removal of the stimulus, it is reversible pulpitis. For the percussion test, it is an examination of the periodontal membrane, not the pulp. You can use the finger or the end of the handle of the mouth mirror. For the mobility test, there are 3 grades. The first grade is 0.2 to 1 mm movement in horizontal direction. For the grade 2, there's more than 1 mm movement in a horizontal direction. And for grade 3, there's more than 1 mm movement in horizontal direction with vertical movement. For radiograph examination, as you can see for tooth 2-1, the crown, there's loss of enamel at the distal portion. The root is single straight. Periodontal membrane, normal. The lamina dura has disappeared. The alveolar bone still normal. And there's lamina dura thickening at the periapical region. We can suspect that this patient has reversible pulpitis. For tooth 4, 6, 3, 6, and 3, 8, we suspect that the tooth has fractured, leaving the radix. We can diagnose that 2-1 has reversible pulpitis, and for 3, 6, 3, 8, and 4, 6, the tooth fractured, remaining the radix. For tooth 2-1, the reversible pulpitis is caused by a traumatic injury, which caused pulp exposure in a fractured tooth. There are 2 classifications for fracture. First is the Ellis classification, and there's a WHO classification. It is class 1 enamel fracture by Ellis classification and uncomplicated crown fracture by the WHO classification. For tooth 3, 6, 3, 8, and 4, 8, the etiology is dental trauma, which can cause your tooth to be cracked, chipped, or knocked out. For this case, it's caused by an accident. The treatment for tooth 2-1, we recommend indirect pulp capping. For tooth 3-6, we recommend removable partial denture or bridging. For tooth 3-8, we recommend extraction. And for tooth 4-6, we recommend removable partial denture or implant or bridge, but bridging is preferred due to narrowing of teeth. For indirect pulp capping treatment, in the first appointment, the dentist will locally anesthetize the tooth and isolate it with a rubber dam. And then superficial debris and majority of the soft infected dentine will be removed without pulp exposure. The deepest layer of infected dentine will be covered with calcium hydroxide and then sealed with zinc oxide eugenol. The tooth will be left undisturbed for 6 to 8 weeks. In the second appointment, if the clinical and radiographic findings are negative, the pulpal floor will be covered with calcium hydroxide, and then the final restoration will be done.
A bridge is used to replace one or more missing teeth in your mouth. Bridges are fixed in that they are cemented on the supporting teeth, or in some cases, fixed on an implant that has been placed next to the missing teeth. It normally takes 2 or more visits for your dentist to complete the bridge. On your first visit, a local anesthetic is administered to make the procedure more comfortable. During this visit, the supporting teeth, which are typically the ones on either side of the missing tooth, are prepared by shaping and reducing their size. This is done to make room for the crowns that will slide over each of the supporting teeth. These crowns also serve as holders of the pontic, which is the missing tooth's replacement. Next, an impression of the abutments or the supporting teeth is made, so a dental laboratory can custom fit the bridge. Finally, a temporary bridge is inserted to protect the abutments as well as the space between them. In most cases, on your second visit, the permanent bridge is placed and adjusted to ensure proper the bridge is satisfactory. Your dentist will proceed with permanently cementing it into place. The first step in making a partial denture is the preparation of the teeth. During this phase, your dentist may prepare the teeth that the partial denture will use for support. Next, your dentist will take an accurate impression of the upper and lower arches of your mouth and records your bite. The impressions are then sent to the dental laboratory. At the subsequent visits, your dentist will evaluate your bite, test your speech, and check the appearance and function of the partial denture teeth and gums. After the final satisfactory fit and appearance are achieved,
this movie shows the two-step method. In this situation, the flap is raised to expose the bone. The bone is drilled to prepare it for the implant fixture, which is placed and then covered with a cover screw. This cover screw is very thin and just covers the opening of the dental implant. The flap is then repositioned over the implant and sutured into place. After the appropriate waiting time, the implant is exposed, the cover screw removed, and replaced with the healing cap. The tissues are then repositioned around the healing cap and allowed to heal. After the appropriate healing time, the healing cap is removed and the crown base and the implant crown are placed on the dental implant fixture.